Today we're talking about a huge problem in the healthcare industry. You've seen thousands of spines.
Yeah.
What do you want the public to know?
I have so many patients come, they just feel like they're stuck. They feel like they're out of options and they're still just suffering with daily symptoms. Most patients don't need surgery. It's so important for my patients to feel like they have a choice in their care. Here are the options that you have in front of you. You know, you can spend a lot of time and money chasing symptoms, but until you get the diagnosis right, you might be chasing your tail for a long, long time.
49% felt like they were not listened to by their primary care provider. Tell me how you feel about that. Welcome to the Healthcare Revolution podcast, where we empower you to take control of your health, build a community of trust in quality healthcare, and achieve lasting wellness. I am your host, Brad Powell, doctor of physical therapy and an owner of an award-winning clinic here in the Salt Lake Valley. Each episode, we dive into all things rehab, injury prevention, and overall health, bringing you expert insights from leaders across various healthcare fields. Please note, while we strive to provide you with the best knowledge and advice, the opinions shared are those of the experts on this podcast and are not to replace professional medical advice. So let's revolutionize healthcare and wellness together. Today I have with me my good friend Chuck Jarvis. He is a spine expert, a DNP, doctor of nurse practitioner, and we're so excited to have him on. Welcome.
Sounds official. Thanks for having me.
You
Excited
are
to be
official,
here.
man.
Yeah.
Today we're talking about a huge problem in the healthcare industry. I pulled up a research article that I read a while back, a systematic review from a colleague, Ray Roque, that talked about a systematic review is a really in-depth study. We both know that, right? This is a really good research article that interviewed thousands of individuals, and 49% of them felt like they were not listened to by their primary care provider or their providers as a whole. Tell me how you feel about that.
Yeah, it's interesting. You know, I think as a provider, sometimes it's difficult to put ourselves in our patient's shoes, but it only takes a few experiences being on the other side of that, where either you're on the patient side or a family member's on the patient side, and what it feels like to be actually seen and validated with what is going on in your medical situation or in your loved one's medical situation, because it's so incredibly personal that I think sometimes we get into the routine of the side of it that's more treatment-based, focus-based on getting to that outcome, when really you need to take that time and say, this is very personal for this person, and imagine going through it without feeling like somebody's even listening, you know?
Do you have a story that you'd share on maybe a family member or you yourself that have gone through this?
We've had a few. My wife, I mean, I'm a proud father of 4 kids, and she had a pretty traumatic experience after our first, where she had a lot of complications with the recovery and with symptoms after that. And we spent years helping her try to figure this out. And so many times we would just get turned away or said, you know, you're fine, or there's nothing wrong. And we went to specialists, we went to therapists, we went all up and down the medical spectrum. And we did find some providers in there that actually, you know, took the time to listen, and not that they always could find the results for us or that they could provide something unique or different, but just having somebody that would say, let me try to find something.
Yeah.
Let me show that I care, even though it's not within my, you know, typical treatment algorithm type of thing. And so that experience made me realize, I mean, when we were going through that, I was kind of finishing my nursing degree. And
so you were in the thick of it, and you're
like,
is this what I'm going into?
Yeah, and so, I mean, I think that I internalized that in a lot of ways. And so even as a bedside nurse in the hospital, I always really felt like it was important to listen to patients and family members. And, you know, even if I didn't have all the answers, at least, you know, show them that I wanted to hear what they had to say and validate them. Yeah.
Yeah, I mean, my wife, when I was in PT school, she had a hamstring strain. I've talked about this on the podcast before, but she went and she saw 5 different providers, and we just went from one thing to the next, and it seemed like a simple hamstring strain, right? Sure. And it's like, why are we going through all this? She went through multiple physical therapists, all the best that I knew, and she went and saw a PM&R doc, and this PM&R doc immediately just said, without even listening to her, just looked at her history and said, yeah, you just need to stop drinking energy drinks, stop eating sugar. I want you to watch this documentary. Literally, she didn't even say anything.
Yeah.
She's like, I just got this chronic hamstring strain. And he pretty much shut her down, gave her the information. Have a great day. Any questions? And she felt so devalued, right?
Yeah.
Like so dismissed.
Mm-hmm.
First of all, she's like, I don't drink energy drinks. She didn't tell him this, right?
Yeah.
I don't hardly any sugar.
Yeah.
And I'm very health conscious. Like, how dare you put me in that category and not even give me a second to talk?
Right.
You literally just wasted my time. I
Yeah.
set this up a month ago, and I'm so disappointed, right? And then
Yep.
she's like, I don't even want to go to the next appointment with
Sure.
someone else, right?
Yeah.
And it's so frustrating, right? Because we put so much energy into what we do, right? But I think it's a really healthy, just like what you said, a reset for us as providers to say, don't be that guy.
Yeah.
You know, tell me some of the things that you do. You know, I've treated a lot of your patients over the years.
Sure.
You know, we've worked together a long time, and you hear how people treat patients, right? And one thing that I've heard consistently about the patients that you work with is you are an exceptional listener, and you help people feel validated and safe. Tell me about some things that you do in the clinic that help you stay focused on the patient and truly listen.
Yeah, I mean, I think it's important to get to know some personal details about the patients you're working with, like what their goals are, what they want to achieve with their treatment.
Yeah.
Because I think that can really help you tailor.
So you're essentially listening to their story.
Yeah, like listen
Kinda
to their
hearing them
story.
out.
Like what? So working in a spine clinic, you know, people are in a lot of pain and they're hurting. But what is it that they're wanting to do that they're missing out on? Like, is it, you know, some patients, it's I need to get back out on the mountain. Like I got an Icon pass and I need to get back out there. Other people, it's I'm going to Disneyland with my grandchildren at the end of the month, and that needs to be a good experience because we've been waiting a long time. So little details like that might seem to some people like, okay, well, I don't care about that. I'm just going to put you in the same box as I would any patient with back pain. But I think that when you make those connections, then when that patient goes through treatment, when that patient faces what they're facing, then you can definitely validate that, hey, I remember this, like I'm going to remember these personal details, like I'm going to help you get to that goal. And it might look like a different treatment path based on what timing we have and what that goal looks like. And I think that goes a long ways because I think unfortunately so many people end up having the experience that my wife had or your wife had where you can get blown off so easily. And especially in the pain world, right?
Yeah.
There's so much stereotype, so much feelings of, hey, I really have nowhere to go and nobody really cares about this.
Yeah, you're kind of the end of the road.
Yeah,
like
and
they've
so
tried everything else.
I think people think that they're really nervous about being put in those boxes. And so treating people like people, I mean, it doesn't really take a lot of high level expertise to recognize that at the end of the day in the medical profession, sure, we're highly skilled, sure, we've got training, sure, we have degrees to back us up, but at the end of the day, it's about how we're treating people and how we're seeing them, like where they are and meeting them, you know, with what they're facing.
Tell me about some of the complications that happen in the clinic that limit your ability to really truly listen to the patient.
Time is always a factor, right? I mean, we're busy. There are a lot of people that we see. There are a lot of folks that have chronic back and neck problems in the community. And so it takes an active effort to take that time to even make those connections and listen the way that you really should. I'm positive I don't hit it, 1,000% all the time, but it's an active effort to like daily remind myself to treat each patient as a high valued individual that you're grateful they're there. And that's multifactorial, really. Like, I am grateful that person's there with me. I'm grateful for the individual that trusted me enough to send their patients to me, that primary care doctor or the therapist that said, hey, you need to go talk to Chuck. He'll help you. And so I value that. And so I think taking that time to really listen to patients when you meet with them is important.
Yeah. Is this one of the reasons why you chose being a DNP?
Yeah,
Is this one of the reasons why you decided to go that route?
I knew that I wanted to advance my training. I received a bachelor's degree in nursing. I was an ICU nurse. I loved working in the ICU.
How long were you in there?
I think it was about 3 years.
Okay.
But I did know that I wanted to pursue further education. And I looked at a few different paths, but I did settle on pursuing a nurse practitioner degree because I love people. I love interacting with people.
Yeah.
A lot of the positions that I was looking at, have varying levels of interaction with others. And I felt like I could definitely help people with my interpersonal skills, help them navigate the healthcare landscape. And so I feel like that's why the nurse practitioner route was a good fit for me.
I love working with DNPs, PAs, because I get so much feedback from patients. They're like, they spent so much time with me and they were so happy to talk to me and they listened. And you have these MDs and I love them
Sure.
all. And I think if they were talking here, they would say the same thing. Like they have a lot more time. DNPs and PAs, they just have more time to connect, right? We have so much going on as MDs and surgeons. Like we got to go through, right? But the reason we have nurse practitioners and physician's assistants is to make that deep connection and make sure they're connected to the MD as well, right? Would you agree? Tell me how that system works with you.
Yeah, I think so. I mean, we work with incredible physicians, and I feel like so much of their talent and expertise that they have is in a highly skilled and trained way that the best that they can do for the community around them is to be doing what they're trained to do at that highest level, right? I mean, I think the philosophy of everybody working to the highest level of their licensure, their training, is when the model works the best. And
I
so
totally agree.
If we can keep our interventional physicians and our surgeons doing the work that they are so skilled in doing, then that is a benefit to the community. If we can keep our nurse practitioners and our PAs educating patients and ordering the right kind of workup and the right kind of treatment to get patients there at the highest level of their ability and of their licensure, then that is really where it functions the best. I think the community is disadvantaged when the opposite happens, where we have surgeons or people being bogged down with referrals that they probably don't need to be seeing, patients that aren't quite ready for them to work on but probably could benefit from another treatment. And so I really feel like that's where nurse practitioners, PAs can kind of be that interplay between folks that have kind of done very basic minimal home treatment but don't need as advanced treatment as, like, say, a surgery. We can be really important in helping navigate that and helping them know which direction to go.
Yeah, I like to think of your role as kind of the orchestra leader. Like, all right, this is where you need to go next, right? You're kind of directing traffic. We just passed this bill at the Senate and the House, and the governor just signed it 2 weeks ago to become primary care providers as doctors of physical therapy.
Oh, cool. Yeah.
So it's like we are an entry point for people to make sure they are not filling up the surgeon's office with patients that they don't need to see, right? And I think, so many people are getting to their offices and it's like, all right, you need to go back to therapy, right? Yeah. And it's just bogging down their system, and they're getting so busy. We need to vet those people out before they get to the surgeon, right?
And I mean, our surgeons would agree that most patients don't need surgery, and so they don't want to be doing surgery on patients that don't need it, right? They really want to only utilize that resource when it's needed. And so, having patient access in various forms is crucial. And I think that's where we've been able to make it work so well at St. Mark's is, so many patients that end up in the ER are there because of back pain. It's a very high percentage of folks that present to our ERs because they're in back pain. And the challenging part is that the ERs really can't do much for them.
Yeah. Give them medication, send them home.
Give them some medication, send them home, and even limited in that area as well. But then it's like, well, where should I go now? Do I need to see a surgeon? Do I want to call an orthopedic surgeon to talk about these things? Or do I go back to my primary care and start over? And so having the spine clinic be kind of that landing spot for all of our initial referrals, we can get folks in within a couple of days and have them seen, and then kind of start that workup that they need to be able to pursue treatment.
I love the system that you guys have. It flows. You have a whole team that all works together, and you utilize each other appropriately. It's dialed in.
I think to your point about, increasing access and having folks be able to, pursue treatment in various paths, a lot of that was kind of brought to light even more so during the pandemic when, we realized what a need there was for healthcare providers and for access to to care, right? Yeah. And so I love that licenses and practices are expanding in that way. Nurse practitioners have expanded their scope as well in the state of Utah, and so it's been a really big blessing to be a practitioner here.
Like what you were saying earlier is the system works really well when we can all exercise our scope of practice at the highest level.
Sure.
We all become experts in our own areas.
Yeah.
I was talking to a friend about this the other day. There's certain providers across the nation that want to be in the driver's seat. It's like, I want to be the driver for all the patients, right? I'm wearing the white coat. I'm going to direct all the work, all these things. But in my opinion, the only person that should be in that driver's seat is the patient.
Yeah.
Like, it's their care.
Yeah.
They get to choose who gets to be in the car with them.
Yeah.
Right? Who do I want in that seat helping me navigate? Right? But if there are 12 seats in that car and each one of us take a role, how much better is the healthcare of that person, right?
Yeah. I think that's interesting, right? Because I've noticed this too in my practice that it's maybe a little bit generational as well.
Yeah.
I think we're in a different space than we were even like 10 or 20 years ago with what that looks like.
Yeah.
It's so important for me to be effective, for my patients to feel like they have a choice in their care. Yeah. And that shared decision making of me saying, this is the situation, this is what it looks like, these are the long-term, prognosticators for how this could go for you. Here are the options that you have in front of you. And let's talk about which one of those is going to be the best for you.
Yeah.
And it's interesting because folks that or maybe like my grandparents or parents' age, when in some cases when I approach it in that way, they're like, well, you're the doctor, you tell me what I should be doing. And I have to kind of have that conversation with them where I tell them that it's really in their best interest for them to be making these decisions with me.
Yeah.
Because
I'm going to educate you on these things and give you options. I'm not going to tell you what to do. Here are your options.
Here are the options. And I think that we're seeing more folks in our generation be more inclined to respond well to that shared decision-making approach, and want to have those options laid out in front of them so that they can help in the decision-making. Yeah. And I think that it's been a net positive overall. I would say that in most cases, I feel like that is part of where patients can really feel validated and heard if they feel like they're part of the decision-making process. And I value it because I will say that I could have two different patients with clinically the same picture, same symptoms, same duration, same severity on their imaging. And I could have two completely different conversations about what the treatment plan is going to be with them based off of just that, us deciding together what's going to be the best fit for them. Some patients come to me with more of a eager, I've been dealing with this back pain for this long. I need to get results now. Help me get where I need to be ASAP. Yeah. Another patient could be experiencing the exact same thing and have the exact same clinical findings, but be more on the line of, hey, I absolutely want to do as little as possible to get the best result I can. Yeah. And I'm willing to do whatever it takes to avoid escalating care in any way. Both those patients can be validated and heard and be treated, but it's going to look a little different, right? And I think that helping them with that and being there to say, okay, well, let me help you go down this road, or let me help you go down that road based off what I'm hearing, then that for them ends up being a better overall experience. And I think really better outcome, because so much of what they're experiencing is, to our point about being heard is, if they feel like they have a good plan and that they are heading in a direction, no matter what that looks like, then in a lot of ways they leave feeling, better off than they did when they came.
Yeah, and ultimately we're here to be guides.
Yeah.
We're not here to tell you what to do. We're here to say, here are your options. Let's help you make a decision.
Yeah.
If someone, what do you do when someone's like, I don't know what to do? Tell me what to do. What do you do in those circumstances?
In a lot of those circumstances, there'll be that response of, well, I get what you're saying about these are my options, but what would you tell your grandma to do, or what would you tell your brother to do?
Yeah.
And I can have some good conversations around that and say, well, with patients I've worked with before, these are some things to consider about going this route versus going that route.
Yeah.
These would be some options if we choose this route, but then it ends up kind of giving us a dead end, and then we end up coming back to another route.
Yeah.
And so sometimes talking through that, I can kind of help guide them into a direction that is consistent with something that I feel is medically recommended, but also in line with what their goals are and what they want to accomplish.
Yeah.
Because if my initial encounter with a patient is off and we're not like on the same path, I probably won't see them again.
Yeah.
I've had that happen.
They just won't come back.
Yeah, they won't come back. Yeah, there's a lot of different places they can go. I mean, it's a highly competitive landscape, and so if I don't find that that jive with them, like initially, and kind of figure out what page they're on, and then help them down that path, then I probably won't see them back.
Yeah.
And so it's important for us.
Ultimately, that's what this podcast is all about. It's the healthcare revolution.
Yeah.
And the revolution being the patient is playing an active role in their own health, right? And not in the sense that they're using Dr. Google and doing all their symptoms. Like, I hope you're doing your research, but then let us be the guide with you, right? There was another study that I read, another systematic review that said that 75% of diagnoses can be accurate just by listening to the patient, right? And diagnostically, we do all these tests, and we're like, okay, test this, test that, right? We're trying to figure out what the tissue at fault is, but it's so great when you just listen to the patient and they tell you exactly what's going on, and then you confirm it with the tests. Sure. It's when we come out of school, it's like, I got to run 50 tests to figure out what's wrong. I got to do an X-ray, an MRI, and I got to run through all these special tests to figure out what's going on. But ultimately, you listen, and then they kind of tell you exactly what's going on, and then you confirm it with some tests, and we're on the right track. Yeah, I mean, you kind of see that as well.
It's interesting too with the spine because as the spine, it's a complex kind of symptomatology, can involve spine and hip. Is there a disc? Does it come from your low nerve? Is it low back? Exactly. So it can be very complex, and you couple that with the fact that people in general over time are going to have degenerative changes in their spine, and that is all part of normal aging processes, right? And so to the point of where the diagnostics come in, you're exactly right, where I can pretty much gauge, I mean, I can have a pretty good guess of where the pain generator is going to be for a patient just by listening to the way they talk about their pain. When it's happening worse, what positions make it worse, where the pain goes, all of these things come together for me to be able to make a pretty clear picture before I've even seen an MRI or an X-ray. And when it comes to coupling that conversation with the imaging, it's very helpful, but it requires a lot of patient education too, because I always tell patients, like, finding the pain generator's got to be the number one goal. I mean, we might be able to see an MRI that has all of this degeneration on it, and your actual pain might be coming from your SI joint, or might be coming from your hip. I had a gentleman a couple days ago that was just 10 out of 10 pain. He's had some back issues before, has been doing all this treatment for his back. He had some stem cells for his back and stem cell injections, gone through all of this stuff, spent a lot of money on treating his back pain. And we just did a plain X-ray of his hip, because the way he was talking to me about his pain, I was wondering if it was more of a hip issue, and sure enough, he has really severe arthritis in his hip. And I said, well, let's look at this first, because maybe we're not even getting the diagnosis right out of the gate. So coupling the
it sounds like in this example, you really listened to him, right? He's been through multiple providers. Right. He's kind of at the end of the road. He's like, I don't know what else to do. Sure. And you're like, let me truly listen to you. It sounds like this is actually coming from your hip instead of your low back.
And I think part of the part that I was going to add to that, part of the complication with his course was that along the road, he did have a spinal MRI that, it does show that he has degenerative disc disease and he has some spinal stenosis. Yeah. But that does not,
and every other 35-year-old.
And every other 72-year-old man who's out there,
Yeah, I mean, you look at studies on these MRIs and, there's tons of really good studies, systematic reviews, randomized control trials on how MRIs, I think around 70% of 40-year-olds have degenerative disc disease, right? But you're trying to couple and you're trying to say, everyone has degenerative disc disease, right? It's a very I shouldn't say everyone, a big percentage of people. Sure. Does that mean that's your pain generator?
Right.
No, that might just be part of normal aging, right?
And that's what I tell patients all the time is, you can spend a lot of time and money chasing symptoms, but until you get the diagnosis right, then you might be chasing your tail for a long, long time, because we see that we use the MRIs and the x-rays a lot to help guide treatment, but we don't treat MRI findings, we treat symptoms. So the same is also true where I've had patients come into my clinic that are in no pain, not having any issues at all, but they were a couple weeks ago and they got a cash price MRI that showed that they had a disc herniation that was barely visualized on the imaging when you look at it, and they're in panic mode because they think they're going to be facing impending spine surgery because they have degenerative disc disease, And so that's a completely different conversation.
What do you think about patients reading and interpreting their own MRIs? Just kind of give me your feedback on that.
It can be a challenging one, right? Because especially in the spinal space, with this conversation we're having about a lot of these things being normal age-related findings, and it's helpful to have and help in terms of helping us plan treatment, but it doesn't necessarily always help us in the diagnosis piece, because again, it's all about where their symptoms are, having that conversation with them, and then confirming it on the imaging on the other side. And it's challenging because, like I said, some patients you're talking them off the cliff because they feel like they're going to be facing some like protracted spinal complication and they're going to be in a wheelchair and be paralyzed. I've literally had to talk people out of that scenario when they're really just experiencing some very normal parts of how our spines all age. We're all going to face that at some point. So having access to that stuff, my chart, MRI results, I'm never going to knock patients having access to their records, and
because you want transparency.
Medical records are very important to be transparent. And I think that the pendulum's come so far on that because there was such a lack of transparency for so many decades and years in healthcare, and people didn't know what they were even being treated for, and they were just being kind of put through the mill of treatment. And so I totally get where they're coming from on having it. I honestly wish that maybe there was not a Google to Google some of the things that they see. I don't mind them having access to the record, but then once they start Googling,
it goes down a slippery slope.
Yeah, it just does go down a slippery slope. And
we know what happens to the brain when people hear things like in their fear avoidance that happens. Like, you imagine being told you had degenerative disc disease as a 25-year-old? Like, how is that damaging for the rest of your life?
And you get that email with the MRI report on a Thursday, and we're not there until Monday, and
you got the
maybe
whole
you can't see me till Wednesday, and you got the whole weekend to worry about.
What stories are you
the
telling yourself over and over? Like, and your friends or your family have had back symptoms, and you're like, or back issues their whole lives.
My
and you're
grandpa
like,
had back surgery. I really do feel like I've landed in a vein of healthcare that it's really, there is a great need for education and for awareness and for helping people understand what spine treatment looks like, what expected outcomes are, and what they can expect for long-term
What do you want the public to really understand about spine care? Just kind of general advice, what do they need to know? We all know that around 70-80% of people in the U.S. nationally, maybe even worldwide, are going to have back pain at some point in their life.
That's right. Yeah.
You've seen thousands of spines.
Yeah.
What do you want the public to know?
I think there's a lot you could just kind of put out there around education and helping people understand this idea that, we're all kind of working against a clock in terms of how our spines are aligned and our discs in our spines and all of that. And we want to be proactive in protecting that and working on the right things. And that's all what folks in your field do. The thing that I found to be one of the most helpful mantras to adopt in this field is that people always have options. I feel like I have so many patients come and they just feel like they're stuck. They feel like they're out of options. Yeah. They feel like they've ran the gamut, they've had the treatments, they've done the things, and they're still just suffering with daily symptoms. Yeah. And I don't know what that feels like to experience daily chronic pain for months to years, but I can only imagine what kind of toll that takes. And the data plays it out that, right, like chronic pain, those folks, it does start to affect quality of life and even life expectancy at a certain extent. So I honestly do not feel that I've ever left a patient feeling like they don't have any options. Yeah, and that's my mantra. Like, I always feel like there are options. Yeah. And if we're not hitting home runs with what we're doing, like, let's
switch it up.
Bring something else in. Let's try something, another route and switch it up. But so many people feel like they don't have that safe space to come back to reevaluate. So they end up just hopping around to different places and pursuing different treatment and essentially starting over every time.
Yeah, they're just telling their story over and over and over again. Yeah.
And then they get frustrated and rightfully so.
I think everyone in healthcare should have that same mantra, right? Yeah. My job as a physical therapist is not to get everyone better.
Right.
My job is to help people navigate the system. And if I get to the end of the road and they're not better, it's dang well my responsibility to get them to someone that can help them, right? I should know all my resources in the community to say, all right, we have reached our max. We've plateaued. We're not progressing how we would anticipate. Let me get you to someone else that can take it from here, right?
Sure, yeah.
I know Chuck. He can help you out. He'll be able to give you more options. Right. But we've kind of reached the end of the road with where we are. Right. Yeah. That's my job as a PT to be able to say that, right? And confidently say that rather than, I think the biggest issue is people, providers will just keep treating them until the patient kind of just taps out and stops coming.
Right.
My job is to jump in and say, it's not responding the way a musculoskeletal injury should respond. Sure. Again, my job is not to get everyone better. My job is to get you to the road that's going to get you better. Right. Give you more options than just therapy. Yeah. Right. So what do you get people all the time that's like, I've failed therapy. I've been there before. So let's talk about some options. Yeah. What other options do you have in your toolbox that can help people when they just feel like they've done everything up to that point?
Yeah, it's a great question. That's an evolving space, right? And I think that's what excites me about spine treatment right now is just all of the new and evolving technology there is out there to help with these symptoms. So many patients come thinking, well, I didn't have success with physical therapy 5 years ago or 6 years ago. So now my only option is to either suffer like this or have a big spine fusion surgery, right? What they're missing is that there's this whole ocean of treatment in between those two routes, right? Yeah. Well, who did you see for physical therapy? What kind of therapy was it? What did they do at the therapy?
Key. I love that you say that. It's
all of these things matter. Yeah, all of these things matter. So maybe there's a conversation around that and revisiting some options there. And I've been pretty successful in helping people see the value of a really highly skilled, highly trained therapist that can do right by a patient and be successful. So maybe there's a conversation around that. Maybe there's a conversation around...
You're on this continuum, right?
Sure.
And you're like, what's the most conservative option first?
Yeah.
Let's make sure we really did our due diligence there, and you see with the right lens.
Right.
And then you're going progressively to less conservative or more invasive, right?
Sure. Yeah. And so then, I mean, as we're moving on in that, then there's this whole interventional pain space where, things like spinal injections, ablations, even things like...
Tell us what an ablation is.
Ablation it's a minimally invasive interventional procedure that can help treat chronic back and neck pain.
Yeah.
Folks that have axial back pain that's just a lot worse.
Describe what they do in this procedure.
They use a small ablation catheters that will apply heat to the nerves that feed the joints of the spine.
Just
and
the
the
peripheral
back.
nerve,
Yeah.
right? Like not the main nerves that control
stuff. These
stuff,
small
just
nerves,
the sensory.
these small nerves, their job is to signal pain from those arthritic
it's kind
joints.
of blocking the pain
So
signal.
yeah, it cauterizes those nerves, and that procedure can be super effective for back pain for months and to a year for folks. And so,
and what I love when people get stuck in therapy, and we've got injections, and they may have helped a little bit, but we just can't get that breakthrough. When people get an ablation, it's so helpful to go back to the drawing board and say, okay, now that you're out of pain, let's get you moving better, decrease these compensations that you're having, strengthen this area, build it robust, and then move you forward, right?
Sure. Yeah, and I think that's where that interplay is between therapy and getting the pain controlled, and how those two specialties can really complement each other.
Yeah,
right?
for sure.
Because if we can help, if there can be an interventional approach that can help somebody get the pain under better control, then they're going to be more successful with therapy.
How many injections can someone get in a year before it's causing an issue, based on your understanding?
Yeah, I mean,
these are steroid injections,
steroid
right?
injections, yeah. So we typically don't recommend too many a year. I mean, more than a few a year.
What's the max you'll do? Or recommend?
We'll start to really evaluate it. If we've done like 3 in the past year and it's in the same exact location.
Why do you not like doing multiple? What's kind of the issue with that?
I think part of it is it's a couple fold. I mean, there is small risks of tissue damage and breakdown over time.
Yeah,
but for me,
kind of break
for me, it's really more along the lines of, I want to have something that's gonna be a long-term solution for our patients.
Would you argue, or would you say that you use it more for diagnostic? Like, let's try to diagnose it. We'll reduce the pain, but we got to go somewhere else.
Yeah, I mean, it comes back to that patient conversation, right? Where if you're a patient who absolutely is not a good candidate or wouldn't need or doesn't want something further down the line, then you might be somebody who kind of stays with an injection approach a little longer than somebody else who's like, well, I mean, the injection helped, but I need to get back out on the mountain, and I'm not going to come back for injections 3 times a year. And so what are my other options? Yeah. And so that's a completely different conversation. Yeah. So it really is patient specific. And we have patients across that whole spectrum that, kind of land on a treatment that's right for them. And we help get that maximized and plus as much as we can until, we run out of that option, and then we look at other things.
Yeah. So we got therapy, chiropractic, steroids, ablations. What's your next step after this?
I mean, for some of our kind of more chronic folks, I mean, there's a lot that we're doing more now in the space of basal vertebral nerve ablation, which is ablation inside the vertebral joint, the vertebral body itself. That's a newer interventional treatment. We do some spinal cord stimulation.
Tell us about the spinal cord stimulators.
Yeah.
Are they external, internal? Kind of what invasiveness?
Yeah, spinal cord stimulators can be a great option for chronic neck, back, and radiating radicular pain related to those things. And folks that have had sometimes big complex surgeries that, maybe they really don't need or aren't a candidate for any more surgery, but they still have some chronic residual pain associated with that. Folks with neuropathy, all of these things can be kind of this chronic pain cycle, and the spinal cord stimulator can help be a device that's non-opioid, non-medication that can help break that pain signal. And that's where they place a couple of...
pretty much you have pain going to your brain saying pain, and it's kind of desensitizing or down-regulating that pain signal.
Yeah, so the leads of the stimulator are planted in the epidural space, and then it's permanently implanted under the skin and all of that. And yeah, it basically breaks that signal.
What I love about it is it's keeping the natural tissue of the human, right?
Yep.
We're talking about this continuum of once you get a fusion, there's no going back.
Yeah.
Right? You're removing natural, normal tissue that you're decreasing disc height, obviously taking the disc out, right? Microdiscectomy is decreasing a disc. So it's so important to be able to follow this continuum and do the most conservative first, because again, once you get those surgeries, there's no going back.
Yeah, I mean, and I think, so those options are very, very worthwhile, and you want to exhaust all those options you can. I think on that far end of the spectrum, I'm also having a lot of conversations with folks around, hey, the surgery your grandpa had or the surgery your dad had 20 years ago is going to be different than what might be recommended for you.
Sure. Yeah.
And maybe let's just go have the conversation and see what that would look like for you, because it's not going to be the same. Things have advanced. There's a lot more technology. There's a lot more minimally invasive procedures. And so a lot of times, to the far end of that spectrum, as you're approaching kind of more of the terminal surgical interventions, what are the minimally invasive surgical options you have, and what would that look like?
Yeah.
And how can those come into play here? And I find that having that conversation with folks is sometimes enlightening for them too, because they're only thinking about worst case scenarios.
I got the same one my dad got.
Yeah. And I out of the gate do not give surgical opinions, because I feel like those are best given by folks that are going to provide the surgery and do the procedure. But I can say, hey, these are some options they might discuss with you, and these are some things maybe you should look at, so that you can, again, back to the point of patient advocacy, but that you can make the best decision that's right for you, because you're going to make the best decision with all the information on the table. And even if you go and talk to the surgeon and you say, thanks, that sounds great, but I don't want any part of that right now, you can come back to me and we'll, try another approach to an interventional injection. Maybe we try a different level. Maybe we try a different medication. Maybe we try something else.
I love this, but at least you're options.
But at least you're making the decision with all of the information on the table.
Yeah, absolutely. Yeah. Let's we'll kind of wrap this up. But what advice would you give patients that have not felt like they've been listened to? What advice would you give them to help their story be heard?
Yeah, I think that it's important for patients in my specialty in the chronic pain space, in the spine and pain space, that patients come with a really clear understanding of what their goals of treatment are.
Just have some clarity on where they want to go.
Have some clarity of what they want to achieve, and I can't tell them what that is, but coming with some of that information can be incredibly helpful, because a lot of times you sit down with the patient and say, well, where do you hurt?
Yeah.
And it's, head, shoulders, knees, and toes, all of the above. Where do we start? And then the follow-up question to me is, okay, well, what is what is affecting you the most? Like, what is limiting you the most? What activities do you want to be doing that you're not?
And sometimes patients will come in and be like, I just want to get back to life.
Yeah.
It's like, okay,
what does that look like?
Yeah, what does that look like for you?
Yeah.
Like, what are you doing? Like, I don't know what your life looks like, right? Can you break that down for me? Just make it really clear in my mind what your life looks like, and then I can help guide you along that path.
And what things need to be changed to make that happen. I've learned my lesson. I mean, I used to spend a lot of time reviewing all this imaging before I even met the patient. And more than one time I will have spent 20 minutes reviewing a lumbar MRI and like combing through it, and I go in there and like, oh man, your MRI of your back looks, oh well, my back's fine, my neck hurts, that's why I'm here, and so
now I think you're going in like, just listening first.
Going and listening first, and then let the diagnostics guide from there. But
I love that. That's great advice. Any other kind of final thoughts on what we want to hear more from patients? What would be more helpful to put them in the driver's seat?
Yeah, I mean, I think that patients are going to make better decisions when they feel like they've been empowered to do so.
Yeah.
And coming to us with this idea that, I'm going to be the one to decide everything for you is going to limit how much we can do. You're going to be a lot better off as a patient if you come and say, hey, these are the things that I want to accomplish. I need somebody to kind of be the home base for that and to help guide me through that and walk me through that. And then that's what we can accomplish for them.
I love it.
Yeah.
That's great advice, Chuck.
Yeah.
Well, thank you for joining us on this podcast today.
Have me back sometime.
Yeah, this has been awesome. I love the message about options.
Yeah.
I love the message about continuum of care and starting conservatively.
Sure.
And look at all the different options. So many people don't understand that it's not PT and then fusion, right? There's just so much in between. There's so much we can do to manage your pain and ultimately abolish it. That's what we're all here to do. But we all have to collectively work together. Each one of us plays a role. And in that process, and it's so important that we utilize each other and talk about this, right? And a lot of therapists don't know these conservative options, right? We should all know what options there are. We're not educating